understand the food route, we have to know about the sciatic nerve first. Sciatic nerve arises from L4 to S3. This is the main nerve of the lower limb and is a continuation of the sacral plexus. It is composed of two parts, namely the outer common peroneal part that arises from the dorsal division of the anterior primary rami of the L4 to S3 and an inner tibial part that arises from ventral divisions of anterior primary rami of L4 to S3. Here we can see the nerve roots and how the lumbar plexus forms and how the sciatic nerve forms and the course of the sciatic nerve. After arising from the plexus, the nerve exits out of the pelvis through the sciatic notch, passing just below the piriformis to enter into the gluteal region. Here it can be located at the midpoint between the greater trochanter and the ischial tuberosity. It descends down under the gluteus maximus and enters the back of the thigh and finally terminates at the apex of popliteal fossa by dividing into the common peroneal nerve and the tibial branches. Here we can see that once the sciatic nerve forms and comes out of the pelvis through the greater sciatic notch just below the piriformis and enters the posterior compartment of the thigh, and then it enters the popliteal fossa. There it divides into the common peroneal nerve and the tibial nerve. Common peroneal nerve supplies the lateral and anterior compartment of the leg. Tibial nerve supplies the posterior compartment of the leg. The tibial part of the sciatic nerve, above its division in the popliteal fossa, supplies the hamstring muscles, namely semimembranosus, semitendinosus, long head of biceps, and ischial head of adductor matrix. The common peroneal part supplies the short head of biceps femoris. The tibial nerve descends at the back of the leg and supplies the calf muscle and the plantar flexors of the foot. Flexor hallucis longus, flexor rigidorum longus, and tibialis posterior. Sensory supply covers the region of the back of the leg and sole of the foot. Latter is the autonomous zone. The common peroneal nerve, CPN, descends on the lateral aspect of the thigh under the biceps femoris to wind around the neck of the block. Soon thereafter, it divides into superficial peroneal and deep peroneal branches. The superficial peroneal supplies the peroneus longus and brevis and terminates by supplying the skin over the lateral aspect of the leg and majority of the dorsum of the foot. The deep peroneal nerve, the counterpart of pin in forearm, pierces the anterior intermuscular septum and enters the anterior compartment of the leg and supplies the muscle of the anterior compartment of the leg. It is the main nerve of this extensor compartment of leg and foot and supplies the dorsiflexors of the foot, namely the tibialis anterior, extensor digitorum longus, extensor digitorum brevis, extensor hallucis longus, and peroneus tertius. It also gives sensory nerve supply to the skin of the first rib space between the first and second toes, which are the autonomous zone for testing the sensory nerve. So here we see a brief outline of the course of sciatic nerve. It forms from the lumbar plexus and then it exits the pelvis by passing just below the piriformis where the lateral sciatic notch descends in the gluteal region under the cover of gluteus maximus, enters back of the thigh, and in the thigh it has two parts: the tibial part which supplies the hamstring and the peroneal part which supplies the short head of biceps, and further divides at the apex of the popliteal fossa into tibial nerve and common peroneal nerve. The tibial nerve descends on the back of leg as a motor and sensory supply. Motor, it supplies the plantar flexus of foot. Sensory, it divides into the plantar branches to the sole of foot, and a sural nerve, it supplies the lateral border of foot till the key toe. Common peroneal nerve winds at the neck of fibula, bifurcates into the deep peroneal nerve and superficial peroneal nerve. The deep peroneal nerve gives supplies motor extensors of foot and sensory web space between first and second foot. Superficial peroneal nerve supplies motor, peroneus longus and brevis, and sensory lateral side of the leg. Saphenous nerve, which is a branch of femoral nerve given the femoral triangle, supplies the medial aspect of the leg and foot till ball of the great toe. Foot drop. Definition: it is the inability to actively dorsiflex and evade the foot. Thereby, the patient drags the foot, which is known as foot drop. Foot drop can arise due to multiple causes. Some of the common causes are ruptured intervertebral disc, total hip replacement, sciatic nerve tumor, and traumatic knee injuries, and injuries to the tibialis anterior muscle. Causes of foot drop can be traumatic. Tendon injuries to the dorsiflexors of foot. So thereby foot dorsiflexion doesn't occur and can be neurogenic at or below the level of common peroneal nerve. Direct injuries, incised and penetrating injuries, fractures and dislocations or indirect injuries. Fracture of lateral condyle of tibia, fracture dislocation of head or neck of fibula, dislocation of knee, open fracture of upper third of tibia. Can be due to iatrogeny. Some of the iatrogenic causes for foot drop are high tibial skeletal traction, tight plaster around the knee, high tibial osteotomy, total knee replacement. Above the level of common peroneal nerve, some of the causes are fracture of shaft of femur, posterior dislocation of hip, deep intramuscular injection, PAVD, spina bifida, if any cerebral tumors, and space occupying lesions of central nervous system. The infective causes are leprosy, poliomyelitis, Guillain-Barré syndrome, syphilis. Metabolic causes are diabetes mellitus, beriberi, alcoholic neuritis, and exogenous toxins, namely lead, arsenic, and mercury, can lead to foot drop. Foot drop develops due to damage to lateral popliteal nerve. The paralysis of the anterior muscles gives rise to foot drop. The characteristic high steppage gait. The ball of foot instead of the heel hits the ground. Inversion of foot leads to overloading on outer part. What are the signs of foot drop? The cutaneous sensation is impaired over the lateral aspect of the lower leg, ankle, dorsal. There's reduced dorsiflexion and eversion of the foot and toe extension. The patients will compensate by having a high steppage gait. Notably, inversion and plantar flexion are normal. The inversion and plantar flexion is done by posterior tibialis, which is supplied by tibial nerve, and hence they are normal. Progressive weakness of the peroneal and tibialis anterior muscles result in foot drop. Peroneus longus, tibialis anterior, and extensor discorum wasting is seen. The paralysis results in ankle weakness and predisposes ankle sprain. Symptoms of foot drop. There is difficulty in lifting the foot because the dorsiflexors of the foot and ankle are weak. Thereby, the patient drags the foot on the floor as one walks, slapping of the foot with each step, raising thigh while walking, and pain, weakness, and numbness in the foot. As there is weakness of the ankle dorsiflexors, the patient compensates this by exaggerated flexion of the hip and knee. This results in a high steppage gait. Types of foot drop. Type 1 is high, which is above the level of fibular head, in which deep peroneal nerve is involved. Type 2 is low, which is below the level of fibular head, in which superficial peroneal nerve is involved. As we have already seen, the deep peroneal nerve supplies the anterior compartment of the leg, and superficial peroneal nerve supplies the lateral compartment of the leg. Similarly, their paralysis will also affect the same compartments. Here we see the course of common peroneal nerve dividing into deep peroneal nerve and the superficial peroneal nerve. Deep supplying the anterior compartment and superficial peroneal nerve supplying the lateral compartment. Clinical features of a type 1 foot drop. High lesion, there is a total foot drop. Patient is unable to dorsiflex and invert the foot, but eversion is possible because eversion is supplied by the superficial peroneal nerve. There is wasting of the anterior group of muscles, which is the anterior compartment muscle. There is loss of sensation over the first rib space. In type 2 foot drop, there is a low lesion, incomplete foot drop, unable to do eversion, able to do dorsiflexion and inversion of the foot, wasting at the outer half of the leg, sensation lost over the outer leg and foot. Namely, the lateral compartment of the leg is affected, which shows it is due to the involvement of superficial peroneal nerve. Foot drop gait. The gait of foot drop is high steppage gait. Patients lift the knee high, slaps the foot to the ground on advancing in the involved strength. The ankle dorsiflexor weakness is being compensated by exaggerated hip and knee flexion. Here we see that the weakness of the ankle dorsiflexion is being compensated by exaggerated hip and knee flexion so that the foot can clear the ground and the patient can walk. Otherwise, due to the weakness of the ankle dorsiflexion, patient will not be able to clear the ground and the patient will drag the foot or otherwise known as foot drop. Coming to the investigations, you can take an X-ray to rule the traumatic causes to the tibia and injuries to the fibula, any bony injuries to the ankle. Anatomic dysfunctions, this charcot joint can be seen with X-rays. Ultrasonography can be done if any bleeding is suspected in a patient with a hip or knee process. A hematoma can compress the knee, compress the nerve. Similarly, magnetic resonance imaging can find out any tumor or compressive lesions over the course of the sciatic nerve. Electromyogram. This study can confirm the type of neuropathy, establish the site of the lesion, estimate extent of injury, and provide a prognosis. Sequential studies are useful to monitor recovery of acute lesion. Treatment. Treatment depends on underlying cause. What is the cause and the treatment? If cause is successfully treated, foot drop may improve or even disappear. Medical treatment, painful paresthesia. If present, we can give drugs such as amitriptyline, nortriptyline, pregabalin, which are all painkillers, usually given for neuropathic conditions. Assistive and adaptive devices and canes, stretchers, or walkers may be used to help patients prevent falling and normalize the gait patterns or unload a painful weight-bearing limb. Electrical stimulation, transcutaneous electrical nerve stimulation for the reduction or obliteration of pain. Positioning, correct positioning of limb. Protective devices and equipment, example, splints, orthosis. Treatment. Conservative treatment shows high incidence of recovery. Splintation. Splint the knee in 20 degrees of flexion and ankle in 90 degrees for night time. In daytime, walking is allowed by using a foot drop appliance. Varieties of foot drop appliances are dynamic spring shoe, static backstop shoe. This is an ankle foot orthosis used for the management of foot drop. Ankle foot orthosis, also known as AFO, supports the foot with lightweight leg braces and shoe inserts. Exercises that strengthen the muscle help to maintain range of motion and improve gait. Electrical function stimulations like TENS can stimulate the peroneal nerve. Nerve stimulation. Stimulating the nerve improves foot drop, especially if it is caused by a stroke. Surgery is done if conservative management fails. Repairs or decompression of a damaged nerve, fusion of the foot and ankle joint, or transfers of tendons from stronger leg muscles are the commonly done surgeries. Surgical options are nerve repair, decompression of the damaged nerve, tendon transfers such as Borst transfer or Ober's transfer, triple arthrodesis, ankle arthrodesis. Tendon transfer surgeries objectives. It provides an active motor power to a paralyzed muscle, eliminates the deforming effect of the paralyzed muscle, eliminate the deforming effect of the active muscle because the antagonist is paralyzed, so there is a deforming effect of the active muscle. Improves the stability, that is the muscle balance. Borst technique is the anterior transfer of tibialis posterior. Classically, the tibialis posterior attachment is removed and transferred to second and third cuneiform or second and third metatarsals. In the modified Borst technique, it is being transferred to the cuboid. The tendon, after the attachment is detached, it is passed through the anterior interosseous main and transferred to the above mentioned site. Postoperatively, a long leg cast is being provided for 3 weeks, and after 6 weeks, the cast is removed, and rehabilitation is done for 6 months using a double ball foot drop brace with an outside T strap, and progressively the muscles are being strengthened and re-educated. The reinsertion of posterior tibial tendon on either second and third cuneiform bone or the base of second or third metatarsal bone after disinsertion from the navicular bone with passage of the tendon through the interosseous membrane of the leg. Ober's technique. The tendon, instead of passing through the interosseous membrane, it is passed through the anterior compartment of the leg. Classically, it attached to the second metatarsal. Hats modified Ober's and attached to the medial cuneiform. Post-op is similar to Borst technique. In Ober anterior transfer of posterior tibial tendon, you can see the line of incision over the posterior tibial muscle. Insertion of the posterior tibial tendon has been exposed, and the tendon has been freed from its insertion muscle, and muscle has been dissected from the tibia. Tendon and muscle pass through the anterior tibial compartment to dorsum of the foot, and tendon has been anchored in the third metatarsal. What are the bony surgeries possible for foot drop? Triple arthrodesis, most effective age more than 12 years. Subtalar calcaneocapoid and talonavicular joints are used. Indications: weakness and deformity of subtalar and mid-tarsal joints. Stable and static realignment removes the deforming forces, arrests progression of deformity, eliminates pain, eliminates use of short leg brace, or provides sufficient correction for fitting long leg brace. Obtains near normal correction of foot. After treatment, walk with crutches or walker. Triple arthrodesis, 3 fusions. Joints to be fused marked in purple. Surgery, lateral incision for triple arthrodesis. Navicular, cuboid, calcaneus, talus are being seen, and here they are fusing the talonavicular, calcaneocuboid, and talocalcaneal joints. This is known as triple arthrodesis. It provides a solid foot and ankle for the patient to weight well more. Ankle arthrodesis, bars and bone. Severe paralytic equinus deformity in adults, subcutaneous plantar fasciotomy, lengthening of tendo Achilles, and ankle arthrodesis. Thank you. So, to summarize the today's topic, it is foot drop, and due to involvement of the sciatic nerve. Sciatic nerve arises from the lumbar plexus L4 to S3, and then it exits the pelvis via greater sciatic notch and passes below the piriformis and enters the posterior compartment of the left thigh, and then it reaches the popliteal fossa where it divides into common peroneal nerve and tibial nerve. The tibial nerve supplies the posterior compartment, and the common peroneal nerve supplies the anterior and lateral compartment of the leg. So, as you have seen the course, the nerve can be affected at any part of the course and resulting in a foot drop. What is foot drop? Foot drop is because there is weakness of the ankle dorsiflexion, thereby the patient is unable to clear the ground, and to compensate it, the patient walks with increased hip flexion and knee flexion. So that is a compensating mechanism for the weak ankle dorsiflexor. On the other hand, the inverters and the plantar plexus are intact because it is supplied by the tibial component, and the posterior tibialis muscle is intact. So thereby, when you are doing surgery, the posterior tibial muscle, which is a plantar flexor and inverter of the foot, is being transferred to the second and third cuneiform to function as a dorsiflexion of the ankle and foot, thereby preventing the foot drop.